In this last presentation related to active euthanasia, we're moving from the question as to whether it's ever right to put a patient to death or help a patient be put to death at his or her request to the matter of public policy. Should voluntary active euthanasia or physician-assisted suicide be institutionalized? That's the question we're considering here. First, it is important to explain what is meant by institutionalization. Obviously, the first thing that is meant is legalization, or we might say the decriminalization of physician participation in voluntary active euthanasia or physician-assisted suicide. Should we make it legal for doctors to help patients put themselves to death or to put patients to death themselves? Secondly, institutionalization also refers to voluntary active euthanasia and physician-assisted suicide becoming an ordinary aspect of medical practice. If that were to happen, those practices would be recognized in the codes of ethics for physicians and other healthcare professionals. It would be reflected in their training. Institutionalization would also mean the offering of voluntary active euthanasia and physician-assisted suicide services in hospitals and clinics. We can imagine them advertising those services. And finally, institutionalization refers to the coverage of those services in public and private health insurance plans. So Medicaid and Medicare might pay physicians to put patients to death at their own request, or to write the prescriptions that patients would use to put themselves to death. All of this would be involved in institutionalization. Now, of course, what we would think about the morality of institutionalization or the wisdom of institutionalization will be closely related to what we think about the morality of individual acts. Obviously, though many folks would oppose institutionalization on the very same grounds that they oppose individual acts. They might well say that active euthanasia is murder and should therefore be, of course, illegal. Now, we need to think about, in that context, our discussion of the relationship between law and morality. Does a prohibition, a legal prohibition of voluntary active euthanasia or physician-assisted suicide on the grounds that it is immoral, fall under the harm principle? That is to say, is this an example of an acceptable intrusion into individual autonomy because it involves preventing someone from being hurt, particularly someone from hurting someone else, a physician from hurting their patients? Or, given the fact that we are mostly talking about approval of something that patients request for themselves, is the idea that we would prohibit voluntary active euthanasia or physician-assisted suicide because we think it's immoral nothing more than an egregious invasion of individual autonomy based in legal moralism? The idea that because most of us think something is wrong, it ought to be prohibited for everyone else. While the concern that the legal prohibition may be nothing more than a very concerning intrusion into individual autonomy, while that concern is surely a legitimate one, you should recognize that the question of social policy or institutionalization is actually significantly different than the issue of individual moral acts. There are, in fact, many folk who believe that individual acts of physician-assisted suicide or even voluntary active euthanasia might be permissible, but still think it would be unwise and even immoral or unethical for us to legalize or institutionalize the practice. The concern has to do with possible abuses of the practice, and some point to a broader concern about adverse social consequences as the result of legalization and institutionalization. Of particular concern is the potential abuse of weak or vulnerable or traditionally discriminated against populations. Let's look at the way John Eris talks about this difference in his article about his experience on a commission in New York that ultimately recommended against a policy approving physician-assisted suicide. Here's what he wrote. Crucial to the task force analysis was the distinction between the morality of individual acts and the wisdom of social policy. Much of the debate in the popular media is driven by the depiction of especially dramatic and poignant instances of suffering humanity desperate for release from the painful thrall of terminal illness. The problem, however, lies in getting from such compelling individual cases to social policy. The issue is not simply, what would I want? But rather, what is the best social policy, all things considered? The task force warns that we cannot make this jump from individual acts to policy without endangering the autonomy and the very lives of others, many of whom are numbered among the most vulnerable citizens. A couple of things to notice here. Eris clearly is sympathetic when it comes to the possible morality of individual acts of voluntary active euthanasia or physician-assisted suicide. He's sensitive to those instances of suffering humanity desperate for release from their condition. He acknowledges, however, that we can't quickly move from that to the question of social policy, because, in fact, the institutionalization or legalization of these actions can in themselves result in threats to the autonomy of others and even to their very lives. We need to think hard about what he means. Consider some of the adverse social consequences that could result from the institutionalization of active euthanasia. Many have been concerned that such an institutionalization could result in disincentives for supportive services for the dying, both palliative care and even for medical research to discover new and innovative cures. The idea is that if we are able to put people to death, at their request, of course, we will have less incentive to try to address pain and suffering more effectively and less incentive for finding cures. A second concern is that the practice of voluntary active euthanasia will undermine trust in physicians and in healthcare institutions. Already there's a concern that many folks present to doctors and hospitals too late because of their mistrust. We do not want to give them more reasons to mistrust their physicians and healthcare institutions. Another concern that Eris specifically mentions is the abuse of vulnerable persons or populations. Let's be honest. We have a history in our society, as does every other society, I suppose, of discriminating against particular persons of color, women, people in poverty. The concern here is that a practice approving voluntary active euthanasia and physician-assisted suicide could result unintentionally of our more easily putting to death persons who have been historically abused, historically discriminated against. Eris himself mentions what he calls concern about slippery slopes. Slippery slope is a metaphor for the idea that once we step across some boundary, the boundary prohibiting voluntary active euthanasia and physician-assisted suicide, we will find ourselves at the top of a very slippery and steep slope. Stepping out onto that slope will cause us to slip and cascade rapidly down into practices that we had not anticipated at the beginning, practices of highly dubious morality.
Eris is concerned about what he calls two kinds of slippery slope concerns. The first one has to do with the logic of the argument, and he was concerned almost exclusively about physician-assisted suicide, because that's what the commission he was on was considering. That the logic of the argument for physician-assisted suicide, grounded in autonomy and beneficence, makes some of the limits that are typically built into such laws seem irrational. So he says, for example, if we approve physician-assisted suicide on a basis of concern about patient self-determination, why should we restrict ourselves to those patients with terminal illness and unbearable pain? I mean, if our concern is simply to give patients self-determination, shouldn't anyone be able to ask for physician-assisted suicide, whether they're sick or not, whether they are terminally ill or not, whether they're suffering or not? If we approve physician-assisted suicide based on concerns about suffering, why limit it to currently competent patients? Now, we would put that limit in place because we were concerned to make sure that we were doing something that was truly what a patient wanted. But if a patient had expressed that previously, now has become incompetent and is suffering, and we want to relieve suffering, why put a restriction in place saying that a person must be currently competent? If, he says, physician-assisted suicide is justified on the basis of autonomy and beneficence, why not voluntary active euthanasia as well? Now, you should be sure to pay attention to his summary of all of this on page 229 in our spiral textbook in the left-hand column. You should be familiar with that passage. Now, admittedly, one may well find those slippery slope concerns related to what he calls the logic of the argument not particularly troubling, if the argument we make about one limited, restricted policy of physician-assisted suicide, for example, applies to a more expansive set of cases, then why not apply it, we might say. That application of our reasoning to a broader range of cases makes perfect, rational, moral sense. His slippery slope concern number two, or his second kind of slippery slope concern, is quite different, however. Here he is concerned about what he calls the likelihood of abuse. That is to say, a concern that patients who actually fall outside the ambit of justifiable criteria will in fact soon be candidates for death. We say, for example, that only those who competently, voluntarily seek physician-assisted suicide or voluntary active euthanasia will get it, but our Eris is concerned that there will be all sorts of subtle coercion and a failure to diagnose and treat depressions that may make a person's choice less than fully voluntary. Eris is concerned about poor treatment for pain, and you should pay attention to his discussion of that on the right-hand column on page 229. He's very concerned that we don't do a good job in our society treating pain and managing pain, focusing on such treatment and care. And because of that, patients will be subtly coerced, you might say, into choosing for physician-assisted suicide or voluntary active euthanasia when they would do differently if we would manage their pain better. Finally, Eris is concerned about the possibility of insufficient reporting of cases of physician-assisted suicide or voluntary active euthanasia, which is necessary for monitoring purposes. Obviously, if we're going to put such policies in place, we need to be sure that they are not being abused. He's concerned about the tension between our desire to protect patient privacy, which would create a tendency not to report the full basis behind the decision to put a patient to death. He's concerned about the tension between that concern and our concern to be able to monitor the practice to prevent abuse. So this, he suggests, is a final reason to be concerned about the institutionalization of physician-assisted suicide or voluntary active euthanasia.
So the bottom line for Eris is this. He says the number of cases in which physician-assisted suicide or voluntary active euthanasia is actually justified is probably quite small, which is to say it reduces the necessity of institutionalization. Secondly, the social risks related particularly to abuses, or the second slippery slope concerns, are serious and quite predictable. And Eris's opinion is that rather than moving toward the institutionalization of these practices, we should be focusing on reforming the way we die in America. If you think back to Gawande's essay on letting go, if we were to move more towards palliative care, an emphasis on palliative care, if we were to move more toward emphasizing hospice care at the end of life, that would be preferable to institutionalizing and making more common the practice of putting patients to death. Eris finally is concerned about creating a situation in which covert or secret practices related to physician-assisted suicide or voluntary active euthanasia might be engaged in by admittedly compassionate physicians. This concludes the first part of our discussion of the institutionalization of active euthanasia. It raises the question as to whether the practice can be sufficiently monitored and controlled to prevent abuse. In the next presentation, we will look at a couple of proposals for regulations that could prevent these negative social consequences and the abuse of the practice that people are concerned about. We'll look at those next time and look a bit at what has happened in the state of Oregon, which is that state that has had the practice of physician-assisted suicide in place for the longest time. That'll be next time in the next presentation.